Today is, what is it today? Today is October 30th, 2023. I have this monthly quiz I have to complete for my residency program. So I'm already into question number 6. So I'm inviting you to join me on how I approach these questions. And of course, if you see anything I can improve on, let me know, because this is a constant growth, right? There's a constant struggle, constant growth, and that's life. So, and if you see any technique I use that might work for you, of course, go ahead and use it. So my main motivation for sharing these things are basically it might help you out. And right here, what I want to show you is this is part of the interface of the ACP, or American College of Physicians MEXAP, which is the question bank they have, MKSAP, MEXAP 19. And I know I'll also enjoy looking back on this in the future. So yeah, so let's get at it. I already did some questions. Let's try to go through this the quickest we can, and I'll just try to think out loud. So you'll see my deficiencies, you'll see any strength I have, and you'll be like, how is it possible this guy doesn't know that, right? Or you'll be like, wow, interesting, or whatever. So let's go. Question number 6. I haven't seen any of these questions before, so yeah, probably there are some questions I might have done in the past, but to be honest, I like studying more with up-to-date, and time has been very short. So let's go right now. Question 6. Okay, first I see the question, which of the following is the most appropriate additional management? Okay, there's several things going on here. Of these, which one, without even seeing the question, what would I say? Stool culture will take weeks to come back, so probably not the answer, unless the patient has a clear treatment already. Stool molecular testing, maybe. Loperamide, yeah, if it's diarrhea, but it's not concerning for anything, you can try to stop the diarrhea, but usually diarrhea, you shouldn't stop it. And levofloxacin, okay, you're treating some sort of bacterial infection there. Okay, let's see. And that's only when you treat it with antibiotics, it's when it's usually bloody and high-risk features. So let's see. 56-year-old man is evaluated for a 2-day history of mild watery diarrhea, current 2 to 3 times daily. So with that, I can rule out levofloxacin, probably stool culture. He has not lost weight. 2 days before symptoms developed, he returned from a 2-week trip to Southeast Asia. Okay. On physical examination, temperature is 37.4, blood pressure is normal, pulse normal, respiratory rate normal, abdomen normal, bowel sounds normal, information regarding oral rehydration is provided. So yeah, he's going home. You don't have to give him an antibiotic. Stool culture is probably viral, to be honest, so this wouldn't even help. Stopping the diarrhea, 2-day history of mild. It's mild. Why do you want to stop it? When it's viral, you actually let the patient, let's get it out of your organism. And that's what I usually do when I worked in hospital in Costa Rica. I would understand this could be an answer. And stool molecular testing, it's like, it's gonna be confined to a certain time frame. So I think it wouldn't be cost effective. Imagine all these mild diarrheas that you're testing the stool, doesn't make sense. So in this case, I would say, okay, loperamide. To be honest, my honest answer would be just oral hydration and just let it go, and you'll take it out of your organism. But based on the options provided, I'd say this is the first possibility, this is the second, and the others, no, not an option. So let's see. Okay, so I got it right. It was the loperamide. So in summary, key points: anti-motility drugs such as loperamide can be used in patients with mild to moderate travelers non-dysenteric diarrhea and as adjuvant therapy in patients treated with antibiotics. Antibiotics are not recommended for mild travelers diarrhea. So yeah, travelers diarrhea is E. coli, E-tech. No, that's enterotoxigenic E. coli. Travelers, there are several. EHEC is enterohemorrhagic. ETEC, well, basically, E. coli, the usual one is the traveler's diarrhea, whatever. So let's go to the next one, and then we'll see specifics, but let's go to the next one. I'll read it later. I just want you to see like what we're thinking and to give me feedback, and for me to enjoy this later when I'm not doing anything related to GI in the future. Okay, so which of the following is the most appropriate treatment? Let's go directly to the options, since I always like reading the whole question and analyzing and all that. But in this day and age, you're always like, move fast. You have these patients, these new patients. We need you to do this now, this, multitasking. So you want to try to reduce the burden of, instead of doing 5 things at once, no, instead of doing, 7 things at once, try to reduce that to 3 things at once. And the way you do that is by working fast. So this is a good test-taking strategy. Most people will tell you to go through these options initially, as we did in the previous question. Which of the following is the most appropriate treatment? Add budesonide. So we're thinking of the inflammatory here, inflammation. Add infliximab, something that's not responding to steroids because first line is steroids. Change azathioprine to 6-mercaptopurine. So that's in case the patient maybe had a reaction to this initial one. And okay, azathioprine to sulfasalazine. So probably this patient is going to have inflammatory bowel disease. 25-year-old woman hospitalized, severe relapse of Crohn's. Okay, ileocolonic Crohn disease was diagnosed 2 years ago. It responded to dose-optimized azathioprine with prednisone. During the past year, 3 disease flares necessitated reintroduction of prednisone despite continuation of azathioprine. Her only medication is azathioprine. On physical examination, vitals normal, abdominal exam, right lower quadrant tenderness, no mass, nothing other than that, a little bit of pain. Abdominal CT showing only bowel wall thickening without significant luminal narrowing of the distal 8 centimeters of the terminal ileum and proximal colon. Basically telling you this is non-surgical. Give treatment, medications, or medications. Colonoscopy shows severe mucosal inflammatory changes, so you have to do something about it, with ulceration in the terminal ileum and proximal colon. So the azathioprine didn't work on its own. The patient has required steroids on several occasions. Budesonide, of course, is another steroid. Prednisone, let's see, budesonide. I've read that budesonide can be used in this context. Prednisone, PO, I think the patient maybe needs something more like that acts there locally. The patient has been on azathioprine, so you could, disease was diagnosed 2 years ago, responded to dose-optimized azathioprine with prednisone during the past. So basically the azathioprine has done something. It's not like you have to just take it out of there altogether. So I think maybe changing the azathioprine isn't the answer. I'm saying that C isn't the answer. I'm thinking that this one isn't the answer because sulfasalazine, azathioprine reduces your immune response. Sulfasalazine will just act locally, so it's different mechanism, and you're exchanging. So I wouldn't say it's any of these two. And infliximab is an anti-TNF alpha, so that could work. And the budesonide is another steroid, and you've already had to give steroids. So it's going to be A or B. I would lean more towards B. And if the answer is A, it is because it's going to say that budesonide is the preferred steroid in that case. But I wouldn't think ACP is giving you an option of a doctor that is doing something incorrectly. So probably the doctor is doing what is correct. So changing, that would mean that the prednisone would make sense. It's not like they're doing iatrogenia, because you usually don't see those cases in clinic in tests unless they specify that the patient is doing an iatrogenia. But this isn't the goal of this question. So I'd say it's this one because, yeah, TNF. Okay, that's the answer. Correct. An anti-tumor necrosis factor agent is most likely to induce and maintain remission of moderate to severe ileocolonic Crohn's disease resistant to glucocorticoids or immunomodulators. Combination therapy with an anti-TNF is more efficacious than monotherapy with either agent alone in achieving glucocorticoid-free remission and mucosal healing in moderate to severe Crohn. So what I would like to know here, just so we benefit from this, is you can see 13% people said budesonide. So let's see why it's not the budesonide. Option A. Various formulations of oral and intravenous glucocorticoids are commonly used to treat mild to severe flares of Crohn's disease. Although they are effective in inducing remission, they are not effective for maintenance therapy and have significant adverse effects. Yeah, so yeah, that's a great point. Steroids, if you send someone to the rheumatologist on steroids, I know one, Dr. Wynn, which is an incredible rheumatologist, an incredible human being. I love Dr. Wynn. Shout out to him. He doesn't like to get patients that are referred to him that have been on steroids for their rheumatoid arthritis for 2 years. He's like, oh man. Because that's not the way to go. Steroids chronically are not the way. You know the side effects. Even they even increase mortality. So when they're used chronically. So controlled release oral budesonide is a glucocorticoid that is effective in inducing remission in mild to moderate ileocolonic Crohn. This patient has severe ileocolonic disease, however, which will likely lead to failure of induction with oral budesonide. Okay, so yeah, severe ileocolonic disease. Okay, perfect. So budesonide works in mild to moderate. This was a little more severe. Okay, let's go to the next one, and it says which of the following is the most appropriate management. Once again, let's see these options. So look at these options. One is surgery, and you also have at the same time colonoscopy. Doesn't make much sense unless the patient has a volvulus, right? That would make more sense, but it wouldn't. The answer, because with the colonoscopy you inflate, you like put in air and it can unwind on its axis and you can just fix it. But there are like two opposite poles, right? For example, if it's toxic megacolon, you don't want to do a colonoscopy because you'll increase the risk for perforation. And that's where you would do surgery. So we'll see. But look, at the same time, we have discharge home with antibiotics or hospitalization. So basically, these answers are all over the board. It's telling you like act now, or no surgery, or surgery, send home, or send or maintain in the hospital. So we're gonna see where there should be a key point that will tell us what's the importance. So 65-year-old woman evaluated in the ED, 2-day history of left lower quadrant abdominal pain and constipation. Okay, could be diverticulitis in that age and that location. She reports having had nausea for 1 day but no vomiting. She has hypertension and type 2 diabetes mellitus, underwent renal transplantation 2 years ago. So renal transplant will require immunosuppression because you don't want rejection of the transplant. So this is a somewhat maybe higher risk patient. I'm not sure if they're putting this in for a reason. Current medications are prednisone, mycophenolate mofetil. So these two are immunosuppressants. So this patient is immunosuppressed. So maybe send in home, maybe not. We'll see. Enalapril and insulin. On physical exam, afebrile, abdomen, lower quadrant tenderness, no guarding or mass. Okay. Hemoglobin is fine. Leukocyte count is mildly elevated. The cutoff is 10, I guess, 10,000. Blood urea nitrogen just mildly elevated. Creatinine is borderline, but it's normal in this lab, 1.3. So all the labs are normal. Let's see what CT says. Diverticular in the sigmoid colon. So I told you it's diverticulitis with bowel wall thickening and pericolonic mesenteric fat stranding, which are findings that tell you this is diverticulitis. no abscess, obstruction, or fistula. So this patient doesn't need surgery. That's answer number 1. It doesn't need a colonoscopy because it increases risk of perforation acutely. So it's going to be one of these two. If the question didn't include that this patient is immunosuppressed, it would be very clearly home with antibiotics. But the patient does have the renal transplant with 2 immunosuppressants on there, so she's immunosuppressed. Sending her home, so that means that maybe she can't mount a good fever response, or she can't, her leukocyte count won't go that high. So even if the CT scan is normal, I'm not sure. So this is one of those patients that probably you get the admission and you're like, should I have this? Should we admit this patient, or should we send them home on antibiotics? But this patient is immunosuppressed. But how immunosuppressed is this patient? Can we follow up this patient in 1 week in the clinic and give the patient antibiotics? Is there any acute organ damage? No, there isn't. To the history, it doesn't say the pain is severe. She is a little bit constipated. CT scan findings are non-concerning. I think which of the following is the most appropriate management? And she's on those medications. We can give her the antibiotics. So it's a very difficult case, right? I would have expected something additional to the creatinine a little bit high for us to say, okay, you're staying in the hospital, so let's send her home. It's plus minus. I would send her home and follow up with her in a week. But the problem is, this isn't asking you what else to do. It's not telling you would be following up in a week. So best practices would probably be sending her home. Let's see. See, that's what I told you guys. See, I had already done this question in the past, sometime in the past 1 or 2 years. So what does it say? Hospitalization and intravenous antibiotics are required to treat acute diverticulitis in patients who cannot tolerate an oral diet with severe comorbidities, advanced age, or immunosuppression for whom oral antibiotics have been ineffective. And patients, okay. So yeah, she's immunosuppressed. It's what I said. Maybe I recalled a little bit of this. So that's it. Let's go on to the next question. Let's see why not sending her home. Home with oral antibiotics, option B. Oral antibiotic consideration for stable immunocompetent patients with uncomplicated diverticulitis. So that's it. But this patient is high risk for poor outcome because they have this comorbid disease with immunosuppression. Okay, let's go on to the next question. Which of the following is the most appropriate next step in management? Endoscopy after 8 weeks of proton pump inhibitor. Endoscopy after 12 weeks. No, I know it's not sounding like good. And a lot of endoscopy options and no endoscopy. So if this is GERD or if this is peptic ulcer and it's the first time, usually you just give the treatment, and if it resolves, you don't need to follow up. So we're gonna see what they're asking or what's going on. 60-year-old man, follow-up of gastric ulcer. He is asymptomatic. Upper endoscopy was performed 4 weeks ago, revealing 1 centimeter clean-based cratered ulcer in the gastric antrum. Biopsy remains specimens negative. Random biopsy specimens negative for H. pylori. Okay. He has discontinued daily ibuprofen. Probably that caused his ulcer in the first place, and now he's taken acetaminophen, which won't cause an ulcer there, and omeprazole. So basically, I would do this one, and I wouldn't follow up on that unless there's something very, very specific. But no, everything looking good, not concerning, no follow-up endoscopy needed. Yes, Routine repeat upper endoscopy for gastric ulcer is not recommended. Repeat upper endoscopy for gastric ulcer is reasonable for ulcers that appear suspicious for malignancy, ulcers that were not biopsied originally, ulcers with an unclear cause, or continued symptoms despite adequate therapy. Okay, next question. Which of the following is the most appropriate management? So this is I'm gonna like this question because I recently had a patient admitted to the hospital with hepatitis B virus. Probably the hepatitis B causing the patient cirrhosis. So if I would have had this question a month ago, I'd be like, oh man, I'm not gonna get it right. But since I had this patient, I went through up to date, I read it again, I refreshed it, and what was the forgetting curve? It was a two-name word, two personal names. Well, whatever. I forgot the forgetting curve's name, but by bringing it back to consciousness, I'm gonna probably answer this correct. So let's see what it says. 29-year-old woman evaluated, let's see the options: antiviral, clinical observation, hepatitis B, virus, immune globulin, and liver biopsy. We'll see. 29-year-old woman, routine follow-up for chronic hepatitis B virus infection. Asymptomatic, no other medical conditions, does not take any medications. She is negative for hep C and HIV. So when you have hepatitis B, you should also check Delta, right? I believe. But, okay. On physical examination, vital signs and other findings are normal. ALT is a little bit elevated because it gets up to maybe 50, 35. Yeah, 35. So it is elevated. How much? Not so much, right? Because when you're thinking of hepatocellular pattern, you're thinking 3 times upper limit of normal. So that would be 30, so 60, 90, like 120, around that. But yes, it's elevated. Hepatitis B core antibody is positive. Okay. Hepatitis B E antibody is negative. Hepatitis B E antigen is positive. I think this one talks about active replication. And hepatitis B virus DNA is very high. When it's higher than 2,000, the cutoff was 2,000 when I saw it recently. So this patient is asymptomatic, doesn't have cirrhosis, so a good differentiation is if the patient has cirrhosis versus no cirrhosis. If the patient has cirrhosis, immediate treatment versus, so I saw this in the context of cirrhosis. This patient doesn't have it, but it does look like the patient is having active replication by these two right here. An increased ALT, a little bit increased, not much. Clinical observation, and I don't think this is the best idea. Liver biopsy, not necessary. Virus immune globulin, I'm not sure. I would do this one. I'd say A or C. Lean more to A. And that's the answer. Treatment of hep B infection is advised for patients with acute liver failure, chronic infection in the immune active phase or reactivation phase, or cirrhosis, and for selected immunosuppressed patients. Immune active chronic HBV infection is defined by the presence of hep B core antibody, elevated ALT level, and HBV viral load greater than 2,000, as I just mentioned. In patients negative for hepatitis B E antigen and greater than 20,000, okay? In patients positive for viral load greater than 2,000, and patients negative for hepatitis B E antigen and greater than 20,000 positive for hepatitis B E antigen. It's a little it's getting me tired. Always that you're seeing the hepatitis B, all these antigens, all these antibodies. I always open up that table on UpToDate or internet, and it'll show you the faces because it always just suddenly hits you like oh man, I'm sleepy. I don't want to see it anymore. So let's try to understand this. Immune active chronic HBV infection is defined by hep B core antibody, elevated ALT, okay, those two things, and HBV viral load greater than 2,000. Okay. In patients, in the patients with negative HBe antigen. And greater than 20,000 in patients with positive hepatitis B E antigen. So that's interesting. So this patient has positive hepatitis B E antigen. So this should be more than 20,000. Okay. If this one was negative, this should be more than 2,000. Next question. Which of the following is the most appropriate diagnostic test? So you have different options. Abdominal ultrasound, yeah, that's very nice. Very low complication rate, and if it works, if it's the option, yeah, you use it. Colonoscopy with biopsy of right and left colon. A little crazy. Stool testing for E. coli 15787, or this is the enterohemorrhagic. So if the patient is bleeding, yes. If not, no. Stool testing for giardia. So giardia shouldn't produce bleeding. This one is giardia produce bleeding. Giardiasis. Yeah, it's a parasite. I think you treat it with metronidazole, right? Giardia. I think it's chronic diarrhea. Don't remember it producing the dysentery, but we'll see. 25-year-old watery non-bloody diarrhea for 9 months duration. It's chronic. Yeah, there you have watery non-bloody. So it's not this one. It's not this one probably. It's not this. It's gonna be this one probably, but not nocturnally. Interesting. It's not at night. It is usually accompanied by abdominal pain in the periumbilical area or left lower quadrant. Pain usually diminishes after a bowel movement. She has had no weight loss. On physical exam, vital signs normal, BMI 22, abdomen is minimal tenderness, left lower quadrant. Labs show normal fecal calprotectin, so no inflammation. TSH is normal, hematocrit tissue, this is for celiac and liver chemistries. The test result for C. diff is negative. So what will a ultrasound help me in the context of this diarrhea? Nothing whatsoever. Colonoscopy with biopsy of the right and left colon. It's a chronic. It's not going away. So yeah, it's watery, non-bloody, okay. But what will you get from that? Is it frequently done by GI? Not something I recall. This one, for sure, it's not. This one is the less invasive of all of them, and it's a strong option. The only thing that's weird for it being giardia is like, why isn't the patient having any diarrhea at night? So it's option D or B. The most logical one would be D, because I haven't seen in my usual rotations in GI anyone sending a colonoscopy with biopsies of the left and right. Doesn't make sense. I would send this one. So let's do that one. Okay, the answer is that one. And as you can see, there was confusion. People weren't sure between those two options. Pretty close, 47 and 46%. So, I had seen this one sometime in the past. The diagnosis of irritable bowel syndrome requires symptoms of recurrent abdominal pain at least one day. Yeah, so that's why I was thinking, if this isn't happening at night, it would be weird for it to be infectious. So it could actually be non-infectious and irritable bowel disease. So I didn't get it right because I knew the diagnosis, because I was like, can this be giardia? But so fecal calprotectin testing to assess for inflammatory bowel disease and stool testing for giardiasis and celiac disease should be considered in patients with chronic diarrhea. Okay, so the importance of giardia was to rule out this. So high sensitivity, I guess low specificity. Basically, just you want to rule it out. So that's the reason you were testing for giardia. If the patient meets the clinical criteria for irritable bowel syndrome with abdominal pain at least one day a week for 3 months and at least two of the following: pain related to defecation, change in stool frequency, or change in stool consistency. Okay, so that's the diagnosis, and it's a rule out diagnosis. So you have to rule out all these things and then decide that. So that was the reason it was the answer. Okay, next question. This whitish, usually these white lesions on the mouth are a couple things. It could be candida. It could also be leukoplakia, I believe, which is cancer. And it could also be virus. Virus can also produce this Koplik spots in measles, right? Can also produce this. So it depends what age this patient is. This isn't a kid. You can see this patient already has some years. So usually when the test asks you measles, they put a picture of a kid or they tell you it's a kid. We'll see. Which of the following is the most appropriate treatment? So 43, let's see the options. Ganciclovir, that is for CMV. Yeah, CMV, that's for CMV. Intravenous caspofungin, no, that's too aggressive. Oral fluconazole, that makes more sense. Oral fluconazole and acyclovir is like, decide yourself. Do you have a diagnosis or not? Is it viral or is it a fungi, right? So upper endoscopy with biopsy and cytologic brushings. Yeah, because I said a differential sometimes is cancer, but let's see what's the history. Previous lab studies revealed a CD4 count of 128. So the CD4 is low when you have HIV. I have a lot of like pruritus, right? I'm having an allergy going on right now. When you have CD4 below 250, that's diagnostic of AIDS. So yes, this patient has risk factors for AIDS. Of course, with that, you also have increased risk for the cancer, and you also have the high risk for candida. So let's see, 43-year-old man can't swallow, has pain, began 5 days ago, solids, liquids, recently diagnosed with HIV on antiretroviral. So I would actually do this because you can't assume it is not the most appropriate treatment. So I think it's good to get a biopsy, but before that, this one would make a lot of sense to me. It's like give fluconazole and that could treat it. And if it doesn't resolve, if it keeps on staying there, you do all this upper endoscopy. So yeah, think about when you're rounding, right? How many patients do you see with this? And you're not gonna be like, oh, upper endoscopy and brushings. No, you're gonna first do this. These two together don't make sense. So I would do that, and I remember I've done that in the past. So okay, what's the reason? Because you want to do something that's cost effective, and if this resolves the problem, that's it. Okay, that's the answer. Candida esophagitis can be diagnosed clinically in patients with dysphagia and endodynophagia. Yeah, they are immunosuppressed, and it can be treated with fluconazole. And let's see why it wasn't the last option. If symptoms are atypical or do not respond to treatment, endoscopy with biopsy or cytologic brushings, what we basically said. Let's go on to the next question. As you can see, the ones that aren't marked in any way or form, I haven't done in the past. The ones that have a small marking, I've done, but I don't remember most of these questions because it's been a while. Which of the following is the most appropriate medical treatment? A, standard dose esomeprazole and broad spectrum antibiotics. Okay, why are you combining those two? I'm not sure. And why broad spectrum? It's like, not sure. High dose esomeprazole, okay. High dose esomeprazole and octreotide, okay. And standard dose esomeprazole. What I recall is that usually these high dose versus standard dose, there's not much of a difference unless there's like a bleed, but we'll see. 58-year-old man hospitalized after having 3 black loose stools in 1 day. Okay, bleeding, melena, probably. He has no other medical conditions, takes no medication, and does not drink alcohol. On physical examination, vital signs normal. Patient appears comfortable with a normal abdominal examination. Anorectal examination shows a small amount of black tarry stool in the rectal vault. The remainder of the exam is normal. Upper endoscopy, 1.5 centimeter gastric ulcer with a non-bleeding visible vessel, which is treated with endoscopic clips. Biopsy of the ulcer is performed, and H. pylori. Okay. So the patient has Helicobacter pylori. Oh no, Helicobacter pylori pending. Okay, so first you just don't start treatment for Helicobacter empirically. You need the diagnosis. So, and this isn't saying quadruple therapy. This is saying broad spectrum antibiotics, which doesn't make sense. The patient doesn't have a cirrhosis or anything for you to give ceftriaxone or medications for SBP prophylaxis. Yes, the patient bled but isn't bleeding right now. Non-bleeding vessel. So, and why octreotide? No, octreotide you give it if there are varicose veins, esophageal varices. So it doesn't say he has esophageal varices. So not this one. Not this one. And immediate treatment. Standard. And why would I give high dose esomeprazole? I'm not sure about that. So usually what I recall, and I've talked about this several times in rounds, is that we give the high dose PPI, but the patient, but I remember that this didn't sound like logical to me. I read somewhere like standard dose does the same, but I'm not 100% sure on the context right now. So it's either B or D, and patient isn't bleeding anymore. Okay, I'll give standard dose. Shit, sorry for the word. So it's high dose esomeprazole. Okay, let's see why. Patients with ulcers at high risk for rebleeding, such as active bleeding, active oozing, or non-bleeding visible vessel. So there's the criteria, right? Los Angeles was for esophagitis, and in the stomach there's another one. Don't remember the name of the criteria you use. Bleeding vessel, it was Forrester. I think the Forrester classification. And there was one, I think it was A, B, and C, then was 2 and grade 3. Grade 3 was like least risky. Grade 1A was like visible bleeding, spurting out vessel. 1B was like you could see the vessel like with a thrombus attached, and 1C was you could see the vessel without a thrombus, and class 2 was remnants of bleed and something like that. So, okay, patients with ulcers at high risk receive high dose proton pump inhibitor therapy for 72 hours while hospitalized, followed by oral PPI twice daily for total of 2 weeks following therapeutic endoscopy. So why wasn't it standard dose? So option D. Patients with low risk stigmata following recent upper GI bleed, flat pigmented spot, clean base ulcer. This is like the grade 3. Not requiring further endoscopic therapy, should receive once daily PPI for 8 weeks. Following endoscopy, these patients can be fed within 24 hours and discharged from the hospital. This patient has a high risk of ulcer. Okay, so that's it with that. Does it say the Forrester classification somewhere here? The high dose esomeprazole was for 72 hours following endoscopic therapy of a bleeding ulcer. So it's defined as more than 80 milligrams daily. Okay, upper endoscopy should be performed within 24 hours in patients with acute upper GI bleed. Within. Okay. Perfect. Let's go ahead. Which of the following is the most appropriate management? So we have colonoscopy, prucalopride. What? First time I read that. Cilium, radiopac, marker study. Okay, all over. 52-year-old man evaluated for 6-month history of constipation. He has bowel movements once every 5 days, lower back pain after 2 days without a bowel movement, and straining during defecation. No abdominal pain. Colon cancer screening was performed 2 years ago with fecal immunochemical testing. On physical examination, vital signs are normal: abdomen, palpable stool without tenderness, digital anorectal examination normal, and hematocrit is normal, right? It's males, yeah, it's normal. Prucalopride, I've never even read about it, so I'm not giving that. Radiopac marker study. So is this con in per enema, like to see the contour of the colon? I'm not sure, but this patient is 52 years old, has chronic constipation, and we could do a colonoscopy, right? That would be the best idea. 2 years ago, the fecal immunochemical testing, but this patient seems to be missing this, and this could also help us out figuring out what's going on. I would do that. This patient needs the most appropriate management. So this is going to be diagnostic, and it's important because not only if you give psyllium makes sense, yeah, you're giving treatment, but it's time to screen again, I guess, because yeah, just fecal immunochemical testing isn't enough. So we're missing something there to cover for screening. So they're not gonna leave it there if we can do something about it. So there's the colonoscopy. It says constipation can be secondary or functional, idiopathic. Medications are the most common cause of secondary constipation. Colonoscopy is the initial evaluation of constipation in elderly patients with acute constipation and patients with unintentional weight loss, family history of colorectal cancer, unexplained anemia, and age older than 45 with no previous colonoscopy. Okay, and let's see why it wasn't psyllium. Psyllium is C. Chronic constipation include serotonergic prokinetics such as prucalopride. Oh, that's okay, perfect. Prucalopride treats constipation. It's a serotonergic prokinetic agent. Okay, first time I read that. I won't remember it until I ever use it on someone, I guess. Vulcan agents such as psyllium, stimulant laxatives such as senna or bisacodyl, as osmotic laxatives, okay, stool softeners, secretagogues, and or biofeedback. These therapeutic modalities are appropriate after evaluation for a cause of constipation. Question number 15. Which of the following is the most appropriate next step in management? Options are discontinue levofloxacin, endoscopic retrograde cholangiopancreatography, liver biopsy, or liver ultrasonography. So usually liver biopsy won't be the answer unless you have already worked this patient up and treatment isn't working, and yeah, there's where biopsy would make more sense, or you're suspecting there's a mass in there, etc. We'll see the other options, what it says. 34-year-old man evaluated for follow-up abnormal liver chemistry results. Abnormal test results were detected 2 weeks ago, and on the day of hospital admission for an ulcerative colitis flare. During hospitalization, treated with glucocorticoids. At the time of discharge, acute prostatitis diagnosed and a 4-week course of levofloxacin initiated. Okay. Follow-up of abnormal liver tests were detected 2 weeks ago. So this was 2 weeks ago when he had this. Then he was given the levofloxacin. These were the liver tests. Alk Phos 258. The normal is until 92. ALT mildly elevated until 35. AST mildly elevated, which normal is until 35. T-bili normal. So Alk Phos is elevated, but T-bili isn't elevated, so this isn't cholestasis. This is just showing us a marker of that. Transaminases are mildly elevated, so it's sort of a mixed pattern. The patient has ulcerative colitis. So ulcerative colitis is associated with liver dysfunction. Oh, it's associated with so it depends. This could be cholestasis, but not at the level of the external. It could be intrahepatic cholestasis. This could be PSC, maybe primary sclerosing cholangitis. But liver biopsy doesn't make sense. Cholangiopancreatography, what are you going to do about it? It's not like the patient is coming in with pain. Stop levofloxacin. Well, the patient already received 4 weeks of levofloxacin. Would make sense to stop the levofloxacin, but they're giving you too much information of other things for the answer to be stop the antibiotic for the prostate. So maybe what they want to get to is that prostatitis treatment requires several weeks. So maybe it's not going to be stop the levofloxacin because it needs 6 weeks treatment. I don't remember exactly right now. I think it was 6 to 8 weeks. Probably the answer will be the liver ultrasonography. But what will you do with that? Liver ultrasound is always a good first step to see what's going on. Oh, there's a magnetic resonance cholangiopancreatography showing normal bile ducts and gallbladder with no gallbladder stones. Okay, so this won't help at all. This won't help. This is like whatever, and probably the answer is this. We want to see if there's dilated canaliculi in there in the liver or something, right? Oh no. Okay, the answer was discontinuation of levofloxacin, so maybe it was, let's see. Primary sclerosing cholangitis, which is what we thought about, is an autoimmune fibroinflammatory disease that most commonly affects large bile ducts, but can also affect the small intrahepatic ducts. It can be diagnosed with magnetic resonance cholangiopancreatography, but the patient didn't have that. Liver biopsy is needed to diagnose small duct primary sclerosing cholangitis. So I still don't understand why the answer is... Oh, it was liver biopsy. It wasn't the levofloxacin. So no one got this right. Almost no one. Okay. Next step in management is liver biopsy. PSC is an autoimmune pro-inflammatory disease of the intrahepatic bile ducts. It most commonly affects the large ducts, but can also affect the small intrahepatic ducts, also associated with inflammatory bowel disease. Okay, so why isn't it liver ultrasound? Probably because it wouldn't help us out that much. Can be useful in the initial evaluation of cholestasis. The presence of biliary dilation on ultrasounds includes blah, blah, blah. Yeah, but we have an MRCP which was normal, and that's more sensitive in diagnosing sclerosing cholangitis. Okay. MRCP, liver ultrasonography will not provide additional information. So the MRCP shows normal bile ducts and gallbladder. Okay. And why was it? Let's see. Liver biopsy. Let's see what about the levofloxacin. So levofloxacin can actually produce this thing, but there was disproportionate increase in Alk Phos compared with transaminases. So levofloxacin is more associated with hepatocellular pattern. Okay, and it was discovered before the patient was started on the levofloxacin. Okay, so that's the answer. There you have it right there. And my question is, for how long is acute prostatitis treated? Two to 6 weeks, acute prostatitis. Okay, there we have the answer. Let's go to the next question. Let's go quicker. Assessment for which of the following conditions is the most appropriate initial management? Inadvertent gluten exposure, microscopic colitis, pancreatic insufficiency, or small bowel lymphoma. So this is probably pretty unusual, so this isn't going to be the answer. 57-year-old man is evaluated for recurrent diarrhea and abdominal pain over the past 2 months. He was diagnosed with celiac disease 10 years ago when he presented with similar symptoms. At that time, symptoms resolved within 1 month of starting gluten-free diet, which he has maintained. He has unintentionally lost 2 kilograms in the past 2 months. And laboratory testing reveals a tissue transglutaminase IgA level of more than 30 times the upper limit of normal. So this is usually telling us that he probably was exposed again to gluten. So initial inadvertent gluten exposure is what makes more sense, and I'll just mark that one, and that's the answer. The most common cause of recurrent celiac disease symptoms is gluten exposure. For the assessment of recurrent symptoms of celiac disease, a dietitian should evaluate possible sources of gluten exposure. Okay, let's go to the next one. Let's make this quicker. You already know how I think, so let's do it quicker. Which of the following is the most appropriate next step in evaluation? CT of the, we don't even know what's going on, so CT of the head, electroencephalography, medication review and reconciliation, neuropsychiatric testing. 56-year-old man evaluated in the ED for progressive confusion over the past 2 days. History of cirrhosis due to alcohol use, but has been abstinent for 5 years. He also has history of depression and anxiety. Escitalopram, which is an SSRI, listed as his only medication. On physical exam, vitals normal, oriented to self but not time and place. Chloroicterus and asterixis are noted. So acute liver failure going on. Remainder of history of exam non-contributory. Specimens obtained for blood and urine cultures and comprehensive metabolic profile. Next step in evaluation. So you got a guy that drank alcohol, now he's having asterixis, chloroicterus, encephalopathy. So by definition, this probably is acute liver failure. I'd probably add an INR to be more sure of this acute liver failure. Electroencephalography will show us that there are brain waves are altered, but will this help us? I don't think so. CT of the head, what will you do with that? Doesn't make much sense. Neuropsychiatric testing, sclerolicterus and all that wouldn't make much sense. This isn't psychiatric. Medication review and reconciliation. Yeah, could he have had acute liver failure secondary to medications? That is a good point, right? He has anxiety and depression, so maybe he has several medications. The first step when you're doing like the admission and all that, I'd say it's this, because electroencephalography, it will just show you slow wave pattern, blah, blah, blah. Okay. CT of the head will be like CT head normal. So this is necessary. That's the answer. The first step in evaluating hepatic encephalopathy. Yeah, he has hepatic encephalopathy. That's what I said, acute liver failure, right? It sounds like acute liver failure, but we don't have the INR. We need that. So, yeah, it's hepatic encephalopathy. Common precipitants include infections, GI bleed, alcohol, and medications with sedating properties such as benzos and opioids. Perfect. So let's go on to the next question. Which of the following is most appropriate diagnostic test to perform next? We have abdominal Doppler ultrasound. We have abdominal radiography. We have a hepatobiliary immunodiacetic acid scintigraphy and non-contrast abdominal CT. So the HIDA scan, or this long forward thing, you only use that when you're suspecting cholecystitis and you're suspecting the patient has the cholecystitis that is not secondary to gallstones, right? So if not, it's not a test answer. So let's see. 36-year-old woman is evaluated for 3-day history of constant right upper quadrant abdominal discomfort and abdominal distension. No significant past medical history. Only medication is oral contraceptive. So she might have there in the liver, she might have, sometimes they can generate with the oral contraceptives, not an adenoma like cyst or something like that. On physical exam, vital signs normal, palpation, tender, enlarged liver, ascites is present. Okay. Bowel sounds normal. ALT is 152, AST is 138. So she has hepatocellular liver injury, okay, associated with ascites. So abdominal radiography won't show anything. Abdominal Doppler ultrasonography. What will the Doppler show me? Yeah, this is a good idea. Could have. Okay, so maybe she could have a Budd-Chiari, or yeah, Budd-Chiari, which is associated with OCPs. Oral contraceptives can produce the thrombosis there that can lead to hepatomegaly because the blood isn't going back, the increased transaminases, the pain, all that. Yeah, so those make sense. Most appropriate diagnostic test and non-contrast abdominal CT. So there are other differentials. So this is option A or D. Which of the following is the most appropriate diagnostic test? So could this be something else in the liver? Could it, because abdominal Doppler is just showing you the flow, so it's basically very limited to the diagnosis you'll get. So abdominal Doppler will basically be like, okay, is this a Budd-Chiari or not? But non-contrast abdominal CT will show you a little more. Is there a cyst? Is there something like that, right? But why is this 3-day history and she doesn't have any significant medical history? So what in the liver will be producing ascites? So Budd-Chiari makes sense. Most appropriate diagnostic to like, it's the most probable thing would be diagnosed with the abdominal Doppler ultrasonography. A non-contrast wouldn't diagnose that. So I'd say I'd go with the most probable thing, although I understand that this might be the answer due to ruling out differentials. So yeah, we got it right. Budd-Chiari syndrome. Okay, there it is. Diagnosed by Doppler ultrasonography. I had read this in the past, but as you can see, I didn't recall it as well because I just tell you, okay, I know the answer, and don't waste your time. Which of the following is the most appropriate screening strategy for this patient? Fecal DNA testing, fecal immunochemical test, upper endoscopy and colonoscopy, colonoscopy, and wireless capsule endoscopy. So let's see what's going on. 40-year-old woman for stage 1 endometrial cancer diagnosed 6 weeks ago. Colon cancer was diagnosed in her mother at age 55, and her maternal aunt at age 60. So the importance with these diagnoses is that it's usually 10 years before. So mother age 55 would mean that she would have to get screened around age 45, and that's like the earliest we have because her aunt was at age 60. So for now, we're still fine with that. The patient has had total abdominal history. Oh, but she does have endometrial cancer. So maybe if someone else, because sometimes you have these mutations. The patient has had a total abdominal hysterectomy and bilateral oophorectomy. Why? Okay, because she had endometrial cancer. Germline testing confirms MSH2. MSH2 was, not sure right now if it's the Gardner syndrome. Was it Gardner? The one that was associated with endometrial cancer, colon cancer, and other cancers. So fecal DNA testing. Which of the following most appropriate screening? Wireless capsule endoscopy, no. Upper endoscopy and colonoscopy, yeah. Fecal immunochemical test, fecal DNA. DNA test, no. So it's gonna be B or C. The reason wireless capsule is here because it would be associated with the areas you cannot see on the upper endoscopy or colonoscopy, which would be the small intestine, part of the jejunum and ileum. So if we're assuming, the question here is this gene mutation MSH2 associated with small bowel cancer? If the answer is yes, we should pursue the wireless capsule. So I think probably the answer will be between C and D now, if they put in that option. And Gardner's, yeah, I think it might be associated. I'd go with this one on this, but I'm not sure. So let's see. Okay. So it wasn't the wireless capsule, so it was upper endoscopy and colonoscopy. Lynch syndrome, sorry. So MSH2 Lynch syndrome, which is the which one was that one? Caused by germline mutations in mismatched repair genes. Okay, yeah, and that's why you have the increased risk. Patients with Lynch syndrome should be screened for colon cancer with colonoscopy beginning at ages 20 to 25 or 2 to 5 years before the earliest cancer diagnosis in the family, and screening for stomach and small bowel cancers with upper endoscopy between age 30 and 35. Okay, so Lynch syndrome is the, what else? Lynch syndrome, increased risk for colorectal and endometrial cancers, as well as other cancers, such as stomach and small bowel. Routine wireless capsule endoscopy is not recommended unless the patient has iron deficiency anemia. Oh, why is that? Because iron is absorbed in the jejunum. So I guess that's the reason. Anemia in the absence of an obvious source of bleeding following upper endoscopy and colonoscopy. Okay, that's a good clue. So that's it. Pretty interesting. I'm gonna underline this or highlight it. And let's see what was Gardner syndrome. Gardner was like polyps, right? Gardner syndrome. Polyps everywhere. Maybe. Yeah, there they are. Gardner syndrome, rare inherited condition, hundreds of abnormal growths in their large, small intestines. There you have all the, what is it? Polyps? Okay. Syndrome rare, what does it generate? Non-cancerous tumors. Yeah, but this thing can increase the risk for a tumor, I guess. Let's see. Diagnosis, treated, prevention, prognosis. It can't be cured, of course, because you have hundreds of these. Life expectancy, 100% of people who had proctocolectomies were alive 5 years after diagnosis. So yeah, you just have to make sure the patient doesn't have if the polyps are in the colon, better take them out so they don't become cancerous. Okay, so that's it. Let's go back to what we were doing. Let's finish this off. Let's go quicker now. Which of the following is the most appropriate management? Liver transplants, rejection, surgical resection, transarterial chemoembolization, or ongoing surveillance. So let's see if this is treatable or not. 50-year-old man evaluated, routine follow-up. He has a history of cirrhosis due to hepatitis C. He previously underwent successful antiviral therapy. He has never had symptoms referable to liver disease and feels well. He is not taking any medications. Vital signs and other findings are unremarkable. Platelet count is good. INR is good. Albumin is maybe just a little bit low. ALT is good. AST is good. T-bili is good. Routine abdominal ultrasound screening and follow-up MRI shows a 1.5 centimeter lesion in the left liver consistent with hepatocellular cancer without evidence of metastasis. What do you have to do it? Yeah, not transplant. The guy is doing fine. Just take this thing out and that's it. Take it out. Patients with hepatocellular carcinoma who have well-compensated cirrhosis, no symptoms referable to, no evidence of portal hypertension, and normal liver function markers should be referred for surgical resection. Liver transplantation for hepatocellular cancer is the best therapy for patients who also have portal hypertension or features of liver dysfunction. Question 21. Right upper quadrant. Okay. Which of the following is the most likely diagnosis? Autoimmune, drug-induced liver injury, hepatitis A, primary biliary cholangitis. Right upper quadrant ultrasound shows no gallbladder, normal size liver, so that is normal. So, yeah, we can't rule out anything here. T-bili is 15. Okay. So that's interesting. Drug-induced, yeah, so ALT, alk phos is 200, ALT is a little bit elevated, AST is elevated, T-bili is 15, and INR is 1. So it's a mixed pattern. It is both. It is cholestatic and also there's it's a little bit of hepatocellular, but the predominant pattern of injury here is cholestatic. 72-year-old woman hospitalized for subacute onset of jaundice that developed 5 days ago on the second day of a cruise to Central America. She has no known liver disease and reports consuming fewer than 3 drinks a week. No abdominal pain, nausea, vomiting. 5 weeks ago, she was treated with amoxicillin clavulanate for diverticulitis. On physical exam, vitals normal, icterus observed. There are no signs of chronic liver disease. So she's normal, so pretty high. This is going to be hepatitis A because there is no previous history. Amoxicillin, if it produced something, I guess it would be hepatocellular. Autoimmune doesn't seem so, and she traveled recently, and that's the usual thing that happens with hepatitis A. So it's incorrect. So it is drug-induced liver injury. Drug-induced liver disease can result from exposure to prescription and non-prescription drugs as well as herbal and dietary supplements, even if the exposure occurred 6 months before symptom onset. Okay. The most common cause of cholestatic hepatitis is drug-induced liver injury. Okay, so we're learning these new things. So why isn't it hepatitis A? Yeah, I would expect it to be a little more hepatocellular, right? Transmitted fecal oral route. International travel is risk factor. Prodrome of malaise, nausea, vomiting, fever, and right upper quadrant discomfort, followed by developing a jaundice and hepatocellular pattern of injury. So her illness is not compatible with hepatitis A because the incubation period for this infection is 15 to 50 days. Okay, they got me on that one. And it was the medication. So this medication was given how long ago? 5 weeks ago, and it can be even 6 months or more, right? Exposure occurs 6 months, even if the exposure occurred 6 months before. Okay. Next question. Which of the following is the most appropriate management? So intravenous heparin bridging, discontinue heparin, reinitiate warfarin after 30 days, reinitiate warfarin within 7 days. A 76-year-old man evaluated in the hospital 2 hours after diagnosis of a bleeding gastric ulcer and treatment with endoscopic clips. He also has diabetes, mild congestive heart failure, atrial fibrillation, hypertension, and hyperlipidemia. Outpatient medications are warfarin, rosuvastatin, losartan, and hydrochlorothiazide. On hospitalization, intravenous omeprazole was initiated and warfarin withheld. On physical exam, stable, irregular, remainder of exam normal, labs showing hemoglobin of 8, INR of 2.2. So, most appropriate management. So the patient had a bleeding gastric ulcer 2 hours ago with clips placed. So you don't want to anticoagulate. Risk-benefit analysis, you have to have them not anticoagulated. Discontinue warfarin permanently, that's not necessarily the answer. Reinitiate warfarin after 30 days, that could happen, or reinitiate warfarin within 7 days. You put in the clips. He is diabetic, mild congestive atrial fibrillation. How much did he bleed? His hemoglobin went up to 8. But appropriate treatment is like if you discontinue warfarin permanently, you're not given an answer to the atrial fibrillation anticoagulation. So that's not going to be the answer. After 30 days is too much. So it's not B, it's not C. And it's not A, so probably it's gonna be this one. Okay, in patients with gastrointestinal bleeding, resuming anticoagulation within the first week after discontinuation minimizes risk for 90-day thrombosis without increasing risk for 90-day recurrent gastrointestinal bleed. Got it. You could just make sure that the patient is on the right dosing and the patient was taking it and all that. The patient bleeds on this, if you would give me other options, another DOAC or all that, maybe I might choose it. But let's go on to the next question. Which of the following is the most appropriate management? So cholecystectomy, endoscopic retrograde cholangiopancreatography, hepatohyda, or ultrasound in 6 months. So a 67-year-old man evaluated for 1 year, history of vague episodic periodic epigastric pain, reports no other symptoms. You tried PPI without improving symptoms. Vitals and physical unremarkable. Abdominal ultrasound 1.5 centimeter polyp in the gallbladder with no gallbladder thickening, fluid, stone, sludge, and no common bile duct dilation seen. Findings on upper endoscopy with gastric biopsy are normal. What would you do in a polyp in the gallbladder? Nothing special, right? 1 year history of vague periodic epigastric pain. So, don't know. Option B, endoscopic retrograde cholangiopancreatography. No. Will you follow it up? I would follow it up and see how it is doing in time. This is a question I think I had in the past, and I probably marked cholecystectomy. And now, after reading the answer, I think it was you just follow it in time. So let's see. I got it bad again, I guess. I'm not sure. So what does it say? Gallbladder polyp size greater than 1 centimeter is a risk factor for malignancy. Treatments for such polyps should be cholecystectomy. So 1 centimeter polyp and above, act on it. Below that, maybe you could follow it. Okay. Gallbladder polyps associated with gallbladder stones or primary sclerosing cholangitis are more likely to be neoplastic. Okay, let's go faster because I want to work out and I have to see someone in a second. So let's go faster. Okay, what does it look like? It's in an area where it's the knee, it's extensor surface. It looks like dermatitis herpetiformis associated with gluten. And let's see what are the options. G6PD deficiency. Don't think so. Which of the most appropriate management? Well, there are some medications which worsen G6PD. When you have G6PD and you give certain medications, you can worsen the G6PD deficiency manifestations, but I'm not sure if that's that. The tissue transglutaminase IgA level is 2. It is normal, so it's like telling us this might not be celiac. 37-year-old man evaluated for pruritic rash on his elbows and knees for 3 years. Celiac disease diagnosed 7 months ago. Yeah, he is otherwise well. Physical exam is that. Dapsone, you give it usually for Mycobacterium leprae, but what else will you give it for? Not sure. Dapsone can worsen I think dapsone worsen G6PD deficiency. So maybe these two are correlated. Maybe you want to give dapsone, but you first have to measure this. That's an option. If not, I'm not sure what the reason for these two options to be here is. So if that's the reason, it would be D. Hydrocortisone, how do you treat that? It's usually the answer for most out-inflammatory things. And I'd say it's D or B. These two are real crazy. It's like no one would mark these if they hadn't had a clear answer for it. So I'm gonna mark this one. There it is. So it was that one. Dermatitis herpetiformis typically presents with intensely pruritic papules and fragile vesicles that rapidly break, leaving tiny. Yeah. Dermatitis herpetiformis responds rapidly to dapsone. Testing for G6PD deficiency is required before initiation of therapy. Wow, that was a good one. Woohoo! So, question number 25. Which of the following is the most appropriate management? Endoscopic ultrasonography and fine needle aspiration, MRI, surgical resection, or nothing. 65-year-old woman evaluated for follow-up, presented to the ED 2 weeks ago with 2-day history of left lower quadrant abdominal pain. CT revealed diverticulitis and 15 millimeter cystic structure in the body of the pancreas. Her acute diverticulitis has resolved, feels well, colonoscopy scheduled in 6 weeks, has no other medical conditions. Radiology report indicates that the pancreatic cyst has all imaging features of serous cyst adenoma. So you shouldn't do anything. You should chill. You shouldn't get a biopsy. You shouldn't get an MRI. You should. Cyst adenoma is like chill. There it is, chill. Mucin-producing cysts, including intraductal papillary mucinous neoplasms and mucinous cystic neoplasms, are thought to have malignant potential. Non-mucin-producing cysts, such as serous cyst adenoma, have no malignant potential. So that's good for us to review. So which are the mucin-producing cysts, right? How can you differentiate them? So here it says characteristics findings of serous cyst adenomas include multicystic lobulated structures. Okay. So cystic neoplasms of the so which ones are the bad ones? Mucin producing ones. So how do you suspect these? Are thought to have malignant potential but may never become malignant. Okay, so I'm not sure how to differentiate them. So that's a question I have. If any one of you sees this, please in the comment section tell me how do I differentiate these cysts, mucinous from the non-mucinous cysts. But let's continue. Which of the following is the most appropriate management? Eluxadoline. Never read that in my life. Glucose breath test. Why do you send that one? Glucose breath test. Was this lactose intolerance? I think it was lactose intolerance. Stool testing for C. diff toxin and upper endoscopy with duodenal biopsy. So 70-year-old man evaluated 5-month history of bloating and non-bloody diarrhea. Diarrhea occurs 3 times daily. Bowel movements include oil droplets and require multiple flushes. So steatorrhea. He reports no abdominal pain, has lost 2.3 kilograms, physical exam normal, vitals normal, abdominal exam showing diffuse tender to palpation without guarding. Hematocrit is a little bit lowered, tissue IgA normal, and result of Giardia enzyme is negative. Colonoscopy with biopsy is normal. Abdominal CT, multiple diverticular in the jejunum. So yeah, the patient has a low hematocrit, no clear reason for bleeding, and diverticula in the jejunum, which is weird. So the answer here is to not to get a duodenal biopsy. Why duodenal if the patient has diverticula in the jejunum? Not quite sure if I'm understanding this. Glucose breath test? No. This thing, I have no idea. This thing, no. So I just rule out probably this. Well, this one I have no idea. This one doesn't sound good. Lactose intolerance. Maybe it's a ruled out. Once again, maybe they just want to rule out this before they go on to something else. Definitely this one isn't the answer, and this one doesn't sound to be the answer. Diarrhea occurs 3 times daily, bowel movements, oil droplets, steatorrhea. Why will you get steatorrhea? Because of you're having malabsorption. You're having malabsorption, so it could be in the jejunum, duodenum. Reports no abdominal pain, has lost weight. Tissue is giardia negative. Colonoscopy normal. Okay, so yeah, upper endoscopy, it's not the stomach. Is it the duodenum? Maybe that's the reason for the malabsorption. This isn't telling you anything about steatorrhea. I know it could rule out, so I'd say this is first option. Second option, have no idea what this is, but I'd say third option, and this one last option. Yeah, it was the second option. Oh, okay. Causes of fat malabsorption include pancreatic dysfunction infections such as giardiasis and Whipple disease, celiac disease, tropical sprue, and small intestinal bacterial overgrowth. Small intestinal bacterial overgrowth can be diagnosed in the appropriate clinical context with both typical symptoms, such as the one we talked about, and positive glucose breath test. So interestingly here, I hadn't had like the association in my mind of short intestinal bowel obstruction with the glucose. So I thought it was just like lactose intolerance. So now we have a differential for glucose breath test. So I'll mark this one. 27. Which of the following is the most appropriate diagnostic test to perform next? CT angio, barium small bowel follow through, tag red cell, or video capsule endoscopy. 55-year-old man evaluated is followed up for iron deficiency and positive result on stool guaiac testing. Despite excellent preparation and visualization, upper endoscopy and colonoscopy performed did not find the source of bleeding, has no melena, hematochezia, or localizing symptoms, no other medical condition, and takes no medications. Yeah. So no, not this one, not this one, not this one, it's this one. If you're trying to see why the patient is having these things, you can do this in the outpatient setting. That's going to be the answer. So for evaluating stable patients suspected of having small bowel bleeding, video capsule endoscopy is preferred testing for non-diagnostic upper endoscopy and colonoscopy. Tag red cells, it's when there's a bleed that you can't, there's a bleed that, let's see, CT angio is when it's like a quick bleed, but when it's a slow bleed, you do the tag red cell scintigraphy. That's the difference, I believe. Option A. And see, these two do the same thing. CT angio and tag red cell scintigraphy require active bleeding to be effective in identifying a source of small bowel bleeding. Bleeding rates of 0.3 ml per minute for CT angio. As I mentioned, it's faster bleed on CT angio, and if it's lower, you do the red cell scintigraphy, which would be 0.1 or 0.2 ml per minute. Okay. Woo! Let's finish this. Which is of the following is the most appropriate next step in management? Okay. So now, let's see. Okay, one is diagnostic, and this is therapeutic and therapeutic. So let's see if stable or unstable. 62-year-old man admitted to the ICU for hematemesis, has a history of cirrhosis, hemodynamic stabilization, and initiation of octreotide and antibiotics. Physical exam, blood pressure is actually fine, with a pulse rate which is fine, respiratory rate, yeah, no shock index is less than 1. Bowel sounds are normal, abdomen untender, endoscopy reveals varices isolated to the gastric fundus. So this is a weird location. This is usually associated with the splenic vein along the greater curvature of the sternum that have stigmata of recent bleeding. So balloon tamponar, no, you can't do that. Balloon tamponar that I know of, it works when it's in the esophagus. You have stigmata of recent bleeding. So you know where it is. You just have to treat it, right? If it bled recently, the patient is stable. The patient is on medications. You have to try to ligate this and varices. So abdominal CT with contrast, no. Ultrasound, no. Balloon tamponar would mean you would have to inflate the whole thing. So I think you have to just go search it and ligate it. Band ligation. Oh man. Whoa! Almost everyone got it wrong. So let's see what happened. In patients with gastric varices, contrast enhanced cross-sectional imaging should be performed to determine the best treatment. The most appropriate next step in management, I have to call someone I know, is abdominal CT with contrast. Gastric varices occur in up to 20% of patients with cirrhosis and can be challenging to manage. Okay. These complications, treatment options. Treatment options include greater curvature of the stomach, depend on the anatomy of the abdominal vasculature. For isolated gastric varices due to splenic vein thrombosis, splenectomy can be performed to decompress varices. If the portal vein is patent and a suitable splenorenal shunt is available, balloon occluded retrograde transvenous obliteration of varices can be considered. Balloon occluded retrograde transvenous. That's crazy. If the anatomy of the hepatic veins and portal vein branches is favorable, transjugular intrahepatic portosystemic shunt may be the option. To determine the best therapy, contrast enhanced cross-sectional imaging is required. Okay, so why wasn't it balloon tamponar, short-term tamponar of bleeding varices? Best used in unstable patients, as I mentioned. I once had to try to put this in a patient. It's very difficult and you require supervision if possible. Where I was, it was like, go ahead and do it, and don't recommend it. Band ligation effective for esophageal varices as well as in the gastric cardia, which extend from the esophagus to the lesser curvature. Band ligation is effective in these because of their predictable anatomy and more superficial location. In this patient, band ligation is not a good option. Okay, that's the reason it wasn't. Question 29. Which of the following is the most appropriate management? 39-year-old, second to last question. 39 years old, 5 liquid stools daily for 3 months. Urgency and abdominal cramps, no weight loss or rectal bleeding, has history of migraines, has self-imposed strict gluten-free diet for 5 years to prevent migraine. His only medication is ibuprofen a lot of ibuprofen, but there's nothing else. Vital signs and physical is normal. Lab shows hematocrit of 40, so he's bleeding or it's low, and normal fecal calprotectin. So the diarrhea, going on. 39 years old, discontinuation. First thing you want to do is stop the offending agent. Tissue, you don't want to do that. Video capsule endoscopy, no. So which of the following is the most appropriate? There is no weight loss. The patient is young, no family history, so you don't have to do a colonoscopy. So just stop the offending agent initially, I would say. So that's the first thing. Many drugs can cause chronic diarrhea. Discontinuing a potential culprit drug may relieve symptoms and obviate the need for further diagnostic testing. So I didn't know ibuprofen can cause diarrhea. I do know that ibuprofen can cause bleeding, and bleeding irritates and it can cause diarrhea. But I'm not sure if because the hematocrit was just mildly reduced. So for him to have diarrhea daily, it's not because of the bleed. The temporal relationship between starting a drug and diarrhea onset can be helpful when present. Okay, so reasonable is to discontinue the potential culprit. Okay, so NSAID implicated in chronic diarrhea. The mechanism by which ibuprofen causes diarrhea is uncertain, but this effect sometimes occurs in the context of microscopic colitis. So in the comment section, teach me a little bit about microscopic colitis. Tell me a brief summary, where you see it, what do you do about it, and yeah. Last question to finish. Which of the following is the most appropriate diagnostic test to perform next? Okay, we have all these tests. 69-year-old man seen in the ICU for sudden onset severe constant periumbilical pain. He was admitted 2 days ago for new onset AFib, a rapid ventricular rate and heart failure. He reports an urge to defecate but has not had a bowel movement in 2 days. Current medications are metoprolol, furosemide, losartan, and heparin. On physical, has shock index is more than 1, meaning that the heart rate is above the systolic blood pressure, so he's not doing that good. Respiratory rate is 24. Patient has significant pain. Cardiac examination shows irregular rhythm. Abdomen non-distended and soft with mild tenderness to deep palpation in the mid-abdomen. Bowel sounds present. Rectal examination shows brown stool. Hemoglobin is normal, or a little bit decreased for him. He has anemia. He has a leukocytosis. He has low bicarb, so we could say just off this, it's not called acidosis. Yeah, it's not called acidemia, because we don't know the blood's pH, but we know there's acidosis because the bicarb is low. Lactate is elevated. So all these things, and the periumbilical pain and all that, would make me think a little bit of mesenteric ischemia. Old person or somewhat old with risk factors. So with AFib, with RVR, the RVR lowers the probably perfusion to the organs and may manifest mesenteric ischemia. But we'll see which of the following is the most appropriate, and the lactate is elevated. So CT angiogram is what you would do for mesenteric ischemia. Colonoscopy with biopsy. Doppler, no, I would go to this one. I'm already tired. Let's call it a day. Let's go for that one, and we got it right. Early acute mesenteric ischemia most commonly presents with abrupt onset of severe periumbilical abdominal pain followed by the urge to defecate and then unremarkable abdominal examination. That's true. Soft, soft, bowel sounds preserved, and I press and the patient jumps up and you're like, but what? This doesn't make sense. Mesenteric ischemia. And lactate elevated, oh man. CT angiography is the recommended imaging modality for the diagnosis of mesenteric ischemia, and that's the end. I had done some questions first, got a 69%. You could go through all my mental framework, and as you can see, the grade doesn't sound good. It's like 69%. That sounds bad. But when we go through all the process of doing this, you're like, oh, yeah, I actually feel I know something. And we thought through a lot of things pretty good. And hope you like this. Give me feedback and see you in the next one.